Good afternoon, everybody. On behalf of the American Heart Association, I would like to welcome you to today's webinar, Decision Algorithms for Treatment in Acute Ischemic Stroke, Part 1. The educational content for today's webinar is made possible by HCA Healthcare and the HCA Healthcare Foundation. HCA Healthcare and the HCA Healthcare Foundation are proud to be the national sponsor of Getting to the Heart of Stroke. My name is Theron Leash, and I am the National Program Manager for Getting to the Heart of Stroke and for today's webinar. Before we begin, I'd like to review a few things on this platform. If you have the opportunity to submit text questions to today's presenters in the questions section, you can send your questions in at any time, and we'll review those questions during our Q&A at the end of the presentation, if we have time available. If you can see on the slide, if you have experiencing any technical difficulties, please try to refresh your browser. Access to captions, please look at the closed caption button found on your screen. Feel free to ask questions again, typing them into the chat in the Q&A box. There is going to be a PDF presentation available in the resource tab. All recordings for the sessions will be available on the Zoom events platform in the weeks to come. So today I'm going to introduce our moderator and our panelists today. Dr. John Witt will be our moderator, and our panelists today are Dr. Marshall Hall, Dr. Jonathan Scoville, Dr. Dennis Cole, Dr. Colby Jones, and pharmacist Cody Pitts. Here's our disclosures from our panelists and our presenters today.
Well, let me go ahead and welcome everyone. My name is Dr. John Witt. I'm a neurologist at TriStar Skyline Medical Center in Nashville, and we're really pleased to present this panel discussion to everyone today. And we appreciate the American Heart Association both for all they do in providing education and guidelines for stroke care, and also for facilitating this panel discussion today. So you saw our panelists go by, and we'll be spending a little time talking to each of those. And our goal today is partly to address the new stroke guidelines, which appeared this year, 2026. You may know that this was the first updated guideline for acute ischemic stroke care since the prior guideline of 2019. So there's a lot of new material, and we'd like to walk through some of that and use our expert panelists here to help us all understand how to best utilize those new guidelines and some of the key decision points that go along with them.
Dr. Witt, if I may, before we get into our presentation, I would love to read our disclaimer that the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the Heart Association. The American Heart Association does not endorse any product or devices. And Dr. Witt, we're very excited about this panel discussion. Apology for the technical difficulties in the beginning, but we are ready to get started on this great conversation about ischemic stroke. Thank you, Dr. Witt.
Fantastic. Thank you very much. So we're going to talk a little bit about foundational concepts in stroke treatment selection. And our core learning objectives today are really these. So we'd like to give an overview of the management of acute ischemic stroke, particularly as it relates to the time-sensitive decisions around imaging and treatment selection. We want to note the expanding eligibility for both thrombolytic therapy and mechanical thrombectomy under the new AHA guidelines. We want to talk specifically about imaging modalities and discuss efficient imaging selection, as well as how imaging data is used in treatment selection. And then finally, to proceed with those redefined treatment criteria so that we know many stroke centers are currently trying to understand and assimilate from the new guideline recommendations. Well, if you've not spent time in these guidelines yet, you'll find there are a number of important updates that impact daily stroke practice. So we find expanded time windows for thrombolysis with accompanying imaging criteria, a greater inclusion and specific guidelines for the use of intravenous tenecteplase in addition to the traditional use of alteplase. We see a new endorsement for mobile stroke units when those are available in a community. We have expanded recommendations for the use of mechanical thrombectomy with additional precision on time windows and imaging requirements, favorable vessels to pursue, and core size considerations. And then finally, we also have the first ever consensus recommendations for pediatric stroke pathways. So let's turn to our panel now in trying to answer some of the questions that are likely on everyone's mind. So I'm going to start with a general question, and I'm going to direct this to Dr. Hall, our emergency physician. So Dr. Hall, as you've interacted with your emergency physician colleagues here at TriStar Skyline and with other emergency departments in our region, as well as with our EMS providers, what's been the reaction to the publication of these new guidelines?
Yeah, thank you for having me. We actually began even before these guidelines came out in a few areas, especially the extended window discussion, and we started sitting down with some of our EMS partners as well as our physician partners at other facilities and our facility, and we were having these discussions. And I think there's really two pieces of it. There's a lot of excitement that there are additional treatment options available, and there's some trepidation because it's a big change. On the EMS side, any additional treatment that we can offer at our facilities is impactful. Our EMS partners want to take people to the facilities that can provide the best care, and with these additional treatment pathways that these guidelines open up, EMS is very interested in destination guidelines and how do we update destination guidelines? How do we change what we had been doing before? So that now, just because somebody is outside that 4.5 hour window, does that change where we send this patient? And I think the answer is yes, it probably will. And but how that all plays out is it's still in process. On the physician side, there's a lot of excitement, and we have. For my entire career, and I think really for everybody's entire career, we have been in this time-based paradigm for thrombolytic treatment. And for the first time on the thrombolytic side, we're now talking about a tissue-based paradigm and perfusion-based paradigm. And those time windows go out, they're gone to some degree. And I think it's important to note, I think with our physicians, especially in the ER, the algorithms by which we treat stroke patients has now suddenly gotten has gotten a lot more complex. And used to, it was simpler. And as time has gone, it's gotten more complex. And it's clear that, in talking with my physician colleagues, there's excitement, but there's also some worry because, publication of guidelines is not necessarily the same thing as implementation of guidelines. And so working through the flow and the decision-making process about who qualifies and who doesn't, it's exciting, yet also, in some cases a little, makes us a little nervous, and how are we going to proceed? So I would say it's kind of mixed right now, but I think excitement is winning out.
Fantastic. So, as you say, there's a lot of enthusiasm for expanding treatment opportunities, but also some trepidation around how to properly image our patients and how to navigate the greater complexity of treatment choices. Now, one subject we won't really have time to address today is that of mobile stroke units, but I do want our listeners to know that for some metropolitan areas, treatment decisions are moving into the field as ambulances are equipped with imaging devices and with teleneurology support. And the new guideline supports the value of these so-called mobile stroke units. And those of us in Nashville, for instance, have contemplated whether our city could support and benefit from this. Well, now let me have the panel address treatment time windows. So many of us have lived through a history of stroke care that started with a 3-hour window for thrombolysis. We saw that window expand to 4.5 hours, and we saw the effectiveness then of mechanical thrombectomy proven in several trials, first at 6 hours and later expanded up to 24 hours. So Dr. Cole, as a stroke neurologist, can you give us a summary of how the new guidelines changed the treatment window specifically for intravenous thrombolysis?
Yeah, thanks, Dr. Witt, and thanks everyone for being here. So in terms of the big change from 2019 in the time window, there are now 2A and 2B level recommendations for using CT perfusion to help select patients based on tissue, as we've heard, in the beyond the 4.5-hour window. So for patients with large vessel occlusions or LVOs, there's a 2B recommendation for thrombolysis in the 4.5 to 24-hour window if there's no thrombectomy planned. And for patients without LVOs, but the CT perfusion shows salvageable penumbra, and effectively these are medium vessel occlusions or MEVOs, there's a 2A level recommendation for thrombolytics in the 4.5 to 9-hour window, or in wake-up strokes that are 9 hours from the midpoint of sleep. It's important to note that there are some studies that have come out since the guideline committee met or began meeting in early 2025. So more recent trials like HOPE and OPTION, EXPECTS, TRACE-5, they're not actually included in the guidelines, such that the difference in the time windows for LVO and non-LVO in the extended window are maybe a little bit artifactual, related to the fact that the LVO extended window trials were already published, but the non-LVO extended window trials were not yet published.
All right, well, that's really incredible when you consider that alteplase was once limited to 3 hours from last known well, but now we have studies suggesting safety and efficacy out to 24 hours under some circumstances. So let me ask you, Dr. Cole, how enthusiastic should we really be for treating beyond the 4.5-hour time point? And what do you see as the primary safety pitfalls in doing so?
So if you look at the absolute difference in the primary outcomes in the LVO extended window lysis trials and the non-LVO extended window lysis trials, there probably is a slightly greater effect for lysis in the MEVO, the medium vessel occlusion population. I think that makes sense. We've seen that in many studies for many years. The more proximal occlusions that are longer and more difficult clots to lyse, they're more difficult than those smaller and more distal occlusions. For patients with large vessel occlusions, the preferred treatment pathway based on current data in the extended time window, I think would be to not bridge with thrombolytics and go straight to thrombectomy if the patient's eligible for thrombectomy. That's easy for me to say, working at a comprehensive stroke center where we have ready access to thrombectomy, but I do think there's a question if you have an LVO patient who's at a facility where there's either going to be a delay in thrombectomy or the patient needs transfer to a thrombectomy capable center, whether you consider extended window lysis in those circumstances as a bridge. I think I personally would probably consider it, but we don't have specific trial-based answers to those questions right now. I think my main takeaway from all these studies actually is that extended window lysis is pretty safe as long as the proper precautions are taken. The symptomatic hemorrhage rate in the studies is essentially the same as it is in the early time window. Safety was not only seen in patients who got extended window TNK without thrombectomy, but also in patients who got lytics with thrombectomy, like in the timeless trial. I think the main potential safety pitfalls that are unique to extended window, I think, lie in the interpretation of the imaging. So while CT perfusion is used to select these patients, the non-contrast CT we have to make sure that we're not ignoring that. So remember that CTP uses timing and amount of contrast as a surrogate for what's happening in the tissue, but that only applies to the moment the scan is taken, such that you can have infarcts outside of that vascular territory that are not well seen on the perfusion. You can have subacute infarcts that may not show up, such that your actual infarct size or age may be different than what the CT perfusion suggests. So I think that's important to keep in mind. And having a mantra, I think that CTP helps to select these candidates, but the non-contrast CT really helps to refine those treatment selections.
Great. And I think to clarify for everyone, in the initial standard 4.5-hour window, it's still just non-contrast CT that we need in order to select patients for thrombolysis. Am I right about that?
That's correct. Yep.
Very good. So clearly advanced imaging is playing a new and central role in selecting patients for thrombolysis in the extended time windows beyond that 4.5 hours. Now, most of our comprehensive centers and some of our primary stroke centers have been using advanced imaging along with handheld devices and AI tools for a number of years, but it seems that their use in selecting patients for thrombolysis is rather new. So in a few minutes, I'm going to ask Dr. Jones to walk us through the imaging modalities and some of their pitfalls. But first, let me ask our pharmacist, Dr. Pitts, about the choices we have in thrombolytic agents. So many centers transitioned from intravenous alteplase to intravenous tenecteplase, though some have not, and some may have both drugs available. What do you see, Dr. Pitts, as the salient differences between these two agents? And from a pharmacist's perspective, why do you see the growing interest in tenecteplase?
Thanks. So as you mentioned, we here at Skyline transitioned to tenecteplase about 2 years ago, and I'd say we've been satisfied with that change for some of the reasons you've discussed. Some of the biggest kind of advantages that I've seen is just with it being so much simpler in terms of dosing and administration. I think that yield really kind of has transitioned to faster door-to-needle times, easier interfacility transfers because it's just one less infusion you have to coordinate for transfer, and then less chance of dosing infusion errors, and then ultimately just lower nursing workload during the acute management of these stroke patients in the ED. And really, those are the main salient differences I think we see up front. So Dr. Cole, may I ask you, with the great success we've seen in mechanical thrombectomy and expanded indications for using it, do we still need intravenous thrombolysis for the LVOs population?
So I think the data is still there for bridging thrombolysis in the early time window under 4.5 hours from the last known well in both the anterior and posterior circulation. This should apply to whether you're, I think, at a thrombectomy capable center or not. The only time I may not consider bridging in an early time window is if there's some relative, or especially if there's absolute thrombolytic contraindications that are giving us pause. And in some of those cases, we'll just sort of go straight to thrombectomy. But there's definitely some nuances to that decision making, and I think those are situations where you have to be pretty thoughtful and make sure that you're not going to have any delays to thrombectomy. In the extended time window, there's really not data that shows efficacy for bridging thrombolysis to thrombectomy right now, at least not yet. So guidelines do not currently recommend bridging thrombolytics for LVOs beyond 4.5 hours. But again, as I mentioned earlier, I personally do think there might be a role for bridging thrombolytics in the extended window if there's going to be a delay to thrombectomy, or certainly if the patient requires transfer. With the average door in, door out time in the US being over 2 hours for drip and ship patients, that's a lot of time and a lot of brain cells, that are likely to die if we don't consider bridging lytics in those circumstances. This is my own personal belief. Guidelines don't specifically comment on that. Just to note.
Great. So it sounds like thrombolytics are still highly relevant for most LVO patients. Well, let's turn now to our other main strategy for reperfusion, which of course is that of endovascular thrombectomy. And I'd like to ask our interventional neurosurgeon, Dr. Scoville, what he sees as the major changes in thrombectomy practice as a result of the new guidelines. And if you could, please also touch on the new addition of the pediatric treatment guidelines.
Yeah, thank you. The biggest change in thrombectomy practice for me is that the guideline clearly broadens who we should consider treatable. The classic thrombectomy patient is still that patient with the anterior circulation, large vessel occlusion, and small core. But the 2026 guidelines now support endovascular therapy in selected patients with larger core infarcts and extends that treatment window up to 24 hours in those appropriately chosen patients. It also makes clear that we should not delay thrombectomy in patients who are also eligible for IV thrombolysis, but we should do both quickly and sequentially, as just discussed. A second major shift in the guidelines is broadening not only the infarct size but also the stroke subtype and patient phenotype. We now include selected patients with posterior circulation occlusions thanks to the basilar thrombectomy trials. It acknowledges that even some patients with pre-existing mild to moderate disability, like MRS 3 and 4, may still benefit, especially in the early window of that 0 to 6 hours. At the same time, we saw kind of a boundary that was being drawn with the thrombectomy in the medium to small vessel occlusions not being routinely recommended outside of more selective settings or trials. Operationally, I think the guideline is also pushing us towards a more pragmatic workflow. If you do not have advanced perfusion imaging, the recommendation is not to stop. It explicitly supports using standard CT with aspects to help identify candidates for thrombectomy. So this is not just an expansion of indications, it's also an effort to make endovascular thrombectomy and therapies more accessible across real-world stroke systems of care. And then specifically for me, as both an adult and pediatric provider, it's the pediatric edition, in my view, is one of the most important advances in the entire document. I'm biased because of this, but for the first time, the guideline gives structured recommendations for children with acute ischemic stroke. It emphasizes rapid diagnosis with MRI, MRA, preferred when timely available, and CT is reasonable when it is not. For treatment, alteplase may be considered within 4.5 hours in children 28 days to 18 years with disabling deficits, and mechanical thrombectomy by experienced neurointerventionalists may be effective in children 6 years and older within 6 hours and may be reasonable up to 24 hours when imaging shows salvageable tissue. Just kind of corroborates and defends what we've been doing for a long time, which is taking kind of off-label these adult practices into pediatrics, but now it gives us a clear-cut guideline to do so. So the bottom line for me would be that the guideline does not say treat everybody. It says we now have stronger evidence to treat more patients more thoughtfully, more quickly, and with better system-level coordination. And for those of us who care for children, it is especially meaningful that pediatric stroke has finally moved from extrapolation to formal guideline-based care.
Great. So I've got two follow-up questions for you on that. So it seems like there's much more liberal selection of patients now for thrombectomy, even for instance with larger predicted infarct cores than what earlier studies like DAWN and Diffuse 3 would have allowed. Help us understand what a large core infarct is. How do you determine that as the interventionalist, and what parameters are you personally comfortable with or putting around those cases?
Yeah, so I actually think that this is one of the most enthusiastic parts of the guidelines and about this expansion thrombectomy. To kind of take a step back, if you go back to the 2015 original trials, like Mr. Clean, Extend IA, the number needed to treat was remarkably low, but they limited it to those patients who had small core infarcts, specifically aspects greater than 6. And, even on CT perfusions, they limited the amount of volume that they would take, even in the extended, window trials. So now with trials like Select 2 and Angel Aspect, when you broaden that population, we noticed that the number needed to treat, which was in the early, treatment trials about 2 or 3, has now gone up to about 5 or 7. But that's the key point, is that we're treating more patients to help more patients. And while the individual probability of dramatic recovery may be lower in these large core patients, the population benefit is really real and meaningful. And to be honest, we have to realize that the natural history for a lot of these patients is with a large vessel occlusion. They're going to have severe disability or more mortality. And if we do something while they may still have that disability or mortality, we have a chance to give them a meaningful recovery. So I think that the expansion has been, a natural progression. We started with a highly selected group that was with an effect size which was undeniable. But now, we're broadening it. We're accepting this trade-off for treating more patients, but getting slightly less, you know, um, dramatic responses, but with still good outcomes.
Great. And if I can put you on the spot, so do you personally have limits in terms of either aspect scores or volumetric measures, predictions of core infarct, where you draw the line between what's safe and reasonable and what might be more risky?
I do like how the guidelines kind of talk about this a little bit, where they say even 0 to 2 aspects within 6 hours may be reasonable to do in patients with good premorbid MRSs. I think that when you look at the aspects or the core infarct, the reality is that in that core, there's still salvageable brain tissue. We've done studies where we see that within the core, there's still, that entire block of core is not infarcted tissue. There's still salvageable tissue, and that these patients, when you do a thrombectomy, they have a significant recovery. And so the reality is that I don't have a strict cutoff now. What I do is I like for those patients that are kind of on the edge with a larger core, I like to discuss. I might be more thoughtful. So it's not so much of a reflex to, oh, we're going to take this patient immediately, but I'll talk to, my stroke neurology colleagues, the radiologist. I'll talk to the family members to really identify. So I take a little bit more time to make sure that we're doing the right thing by the patient before we take them back to thrombectomy. But the reality is, for me, I don't have a strict cutoff anymore like we used to. I think that the guidelines kind of have let us say, like, okay, this can be much more individualized by patient, which I think is fantastic.
Excellent. Well, so it sounds like enthusiasm is appropriate, but we also need to refine our skills in imaging interpretation and apply good judgment to those cases with realistic expectations, maybe that we communicate and even over communicate to our patients and their families. So, we've mentioned imaging several times, so I'd like to turn now to Dr. Jones, our neuroradiologist, and ask you to first walk us through the CT-based modalities. What does each modality have to offer? What are some of the pitfalls in interpreting them? And especially as we rely heavily on mobile devices and rely on our CT technicians to complete high-quality studies. How can you enlighten us about those things?
Sure. Thanks, Dr. Witt. First of all, I just wanted to thank everyone for being here and for the invitation to be on the panel. I've learned a lot from multiple people here today. So hopefully I'll be able to give you guys some enlightenment when it comes to the imaging world. CT has really been for years really the driving force when it comes to stroke algorithm decision making, and especially with the non-contrast head CT, which is really the workhorse, if you will, of that initial decision making process for the clinician. And there's a reason for that. The non-contrast head CT is widely available. We already mentioned earlier today the use of mobile stroke units. Even most rural community hospitals have access to CT readily available. Rapid acquisition, also very important when it comes to making time-based treatment decisions. And that not just being the fact that the scan itself is shorter in length than other modalities such as MRI, but also the screening process. There's a very minimal screening process that has to occur before a patient can enter the CT scanner area as compared to other modalities like MRI. So, and then one other thing that I think is sometimes overlooked with CT-based modality, or the non-contrast head CT rather, is just the cost, overall lower cost compared to other imaging modalities such as MRI. So those are all real positives for the non-contrast head CT. There's obviously two big questions that we like to answer when it comes to interpreting the non-contrast CT. One, is there presence of blood? Obviously, that's going to shift the treatment decision making, dramatically one way or the other. And also, as has been mentioned several times already, the evidence of acute infarct or core infarct on that non-contrast head CT. And keeping those two things in mind, some pitfalls that are very common, and most people know, but I think it's important to kind of reiterate and go over these is that when it comes to posterior fossa infarcts, we know that CT-based modalities have decreased sensitivity for posterior fossa infarcts. Really, it's below 40% sensitivity for cerebellar hemisphere, and I believe even lower than that, like 30% for brainstem acute infarcts. And there's reasons for that. There's obviously this concept of beam hardening, which is an artifact in radiology. When you look at a CT, you may see these dark lines that kind of cross the image, and really that's created by the skull base and the denser bone structures there that affect the photons as they're crossing the scan and causes this artifact, which reduces the sensitivity. And then you did mention the use of mobile devices, and I know there's different platforms and different vendors that will send essentially, AI or software uh, images that have flagged potential aspect scores. And I always tell people to be weary of that and to make sure you look at the imaging yourself because it's not uncommon. I see this almost daily where an aspect score may be lower than it actually is because the computer or the software has flagged an old infarct as part of that now new acute process. So just keep that in mind. CTA, really moving on to the CTA head, is really become, I think, a new standard for evaluation of large vessel occlusion in stroke patients. It's a non-invasive test compared to, back when the neuro fellows were coming in at night to do angios in stroke patients. With newer CT technology, we're able to create extremely thin slice imaging. Most stroke centers now use 0.625 millimeters. You can think about just how small that is. Images in their CTAs, and that also allows us on the radiology side with most PACS vendors to take those thin slice images and create our own reformats, our own MIP images, which are great to help detect more distal vessel occlusions. And I think that technology is outstanding now. And like I said, is widely available with multiple different vendors. I would also encourage as a tip for everyone who reviews a CTA to make sure you are utilizing those thin slice reformats because it will help you detect some of those more distal M2 occlusions as compared to just a standard axial or a thick slice axial CTA image. As far as pitfalls go with CTA, there's obviously a few. It is a iodinated contrasted study. Therefore, if the patient has an allergy, you have to take that into consideration. Although we do have those small, thin slices that we talked about, there's still a limit to what vessels we can actually interpret. For example, any type of perforating vessel, your lenticulostriate vessels, your basilar perforators, there's very limited evaluation of those with CTA. And then also just the bolus itself. And we'll talk more about artifacts later, but there's multiple things that can cause the CTA to have a poor bolus. It could be from the equipment itself, it could be a faulty injector, the IV could not be appropriate, or it could be an underlying condition with the patient. For example, poor cardiac output can affect our bolus timing with CTA, and obviously the less optimal the bolus, the more limited the evaluation is on the CTA imaging. And then finally, really, the CT perfusion study, again, has been brought up a few times already. It's really been remarkable. So just for background, all of my training and practice has happened within the last decade. And it's been interesting to see from the start of my training how the use of CT perfusion has shifted from both the neurologist side and the interventionalist side and who uses it a little more heavily. I think CT perfusion is a great tool, an imaging tip, and how I was trained is that a CT perfusion should always, always, always be interpreted with the corresponding CTA imaging. They really work hand in hand, and it's a great tool, again, to help you find some of those more distal occlusions, your M2 occlusions, for example. If you look at the perfusion and you see a region of hypoperfusion or core infarct, you want to go to that region. For example, if it's an inferior division region of hypoperfusion, you want to look at that corresponding side of the CTA and really scrutinize it to see if you can see exactly where that thrombus or occlusion may be. But CT perfusion obviously has its limitations. And this really goes for any imaging modality, but especially CT perfusion, is that the conclusions and the summaries that you can interpret from the study are really only as good as the data and the technique used to acquire the image. And with CT perfusion, one of the most common kind of limitations that we see in our practice, and really I've seen in other locations, is that it is extremely sensitive to motion artifacts. So if the patient moves, it really will alter your data, and the summary maps that the perfusion software generates may not be accurate. So it's something to keep in mind. I tell during our stroke conferences, or if I'm talking to a resident, I always tell them, one of the first things you should look at with that CT perfusion study is your quality maps. And every vendor has them. They may look slightly different depending on what vendor you have, but those quality maps are really important to look at to make sure that, again, the data that you're looking at and the interpretations that you're making from the study are actually true and adequate. Other limitations with CT perfusion, in early time windows, there is this idea of ghost infarct. So you could potentially be over evaluating or overestimating your true core volume. And then on the flip side, there is a chance that you could be underestimating your core volume in more of a late time window over the kind of past that 6 hour time limit. So all those things are really important to keep in mind with CT perfusion. But again, I do believe that it's a great tool and can be utilized by both interventionalists and non-interventionalists in your decision making.
Great. So thanks for that expert commentary. And let me see if our neurologist and our surgeon have anything to add from their perspective as users of these modalities. So let's start with you first, Dr. Cole.
Yeah, I think it's interesting, kind of what Dr. Jones was alluding to. I think CT perfusion kind of started off being more of a used for thrombectomy and interventional decision making, and especially now with the new guidelines, I think it's still being used for thrombectomy as a sort of an adjunctive, especially in those individualized decision making cases that are kind of in those gray areas sometimes. But especially now, very much has entered the realm for extended window thrombolysis. So it's almost kind of shifted from being mostly for thrombectomy and really not for lytics, and now it's sort of almost flipped a little bit. I touched on this earlier, but a point I wanted to hammer home, especially from my viewpoint as a neurologist and considering extended window thrombolysis, is to really closely examine your CTP. Like Dr. Jones was saying, make sure that it's good quality and that you can trust what the predicted core and penumbra are. And two, to very closely cross-reference that with the non-contrast CT to ensure that there's no infarcts that are outside of what the CTP is suggesting that may shift your thinking about what the actual time course of the stroke is for the patient. If you're seeing subacute infarcts that look days old, those are probably higher risk thrombolytic patients, of course. And so it's really important to examine both of those together.
Great. And Dr. Scoville, how about you? And maybe if you could also specifically answer, as you go from viewing the CTA potentially into the interventional suite to do a catheter angiogram, how confident are you in what you're going to find based on the CTA that you see?
Yeah, today most places have very high quality CT angiograms, and I can be pretty confident that what I'm going to find in the interventional suite with just based on the CT angiogram. Now, every now and again, you'll be surprised, especially if they get TNK. We'll see that the clot has migrated or broken up somewhat, but Most of the time, I'm finding exactly what I thought I was going to find. In terms of decision making, the way that I look at it is obviously when I see the CT angiogram, I want to confirm that there is a vessel occlusion, and so I usually am looking in all three axial, coronal, and sagittal reconfirmations in order to identify it, make sure that that's the correct vessel. There's a lot of, especially with the AI, early warning signs. There's a lot of false positives, and so you want to make sure that that's correct. And every now and again, you'll see a false negative, um, but then, I look at the CT non-con, and I really want to make sure that the CT non-con and the CT perfusion corroborate each other. Uh, I think the CT gives you a structural baseline. You rule out hemorrhage, and then you get the aspects, which is still incredibly valuable. It's fast, it's widely available, and it keeps you grounded for what's already infarcted. And then I look at the CT perfusion, and it adds kind of the physiology. It tells you what's at risk, but not yet lost. So I'm looking at how the aspects aligns with the estimated core on the perfusion, whether there's a meaningful core penumbra mismatch, and then increasing them, looking at things like the hypoperfusion index, which gives me insight into the collateral robustness and if they might be a fast progressor or not. And then when those pieces line up, CT aspects and perfusion maps are all telling the kind of the same story, and the decision making becomes much more confident in patients that we might not have treated in the past. At the same time, I think Dr. Cole talked about the same things. There's some pitfalls. You need to make sure it's good acquisition, timing, motion, and full coverage. And then also depends on processing software, which can vary. And then there's always a risk of over-interpreting color maps without anchoring back to the CT and the clinical exam as well. And so my approach is really, again, just the integration of the CT aspects to define established injury, the CT perfusion to define salvageable tissue, and then the CT angiogram to define the target. And when those three align, you're much more confident in what you're going to find.
Great. Okay. And then maybe on a practical note, I'd just like to add that even at busy, highly skilled stroke centers, not every image reader has the same level of comfort and expertise in reading the images. So I think it makes sense to be collaborative and consider a consensus opinion on image interpretation, and maybe acknowledge our own biases around whether we're looking to be more inclusive or more restrictive in who we select for treatments as we view the images under these new guidelines. I personally find the inter-rater variability for aspects scoring, for instance, to be a bit of a challenge, especially on smaller handheld devices. So I really appreciate it when our radiologists at their diagnostic reading stations are able to affirm, a more accurate score for us. And I'm frequently humbled by findings on angiography that I see reported that sometimes do differ a bit from what we found on CTA. All right. Well, Dr. Jones, I don't want to neglect the potential role for acute MRI. So can you tell us a little bit about how you approach MRI, specifically for diffusion flare mismatch and the evaluation of patients with so-called wake-up stroke?
Yeah, sure. So, MRI really it's truly our most sensitive, our best tool for evaluating and finding acute infarcts. DWI sequences can be positive within minutes after acute infarct, although I will throw in the caveat that within the first 2 hours of presentation or symptom onset, rather, up to 25% of those MRIs can be negative, or the DWI signal can be faintly positive. So keep that in mind when you review those. But yeah, the idea of, and there's different terminologies that you'll hear for this. A rapid stroke protocol, wake up stroke protocol, fast stroke protocol, they all essentially are evaluating for the same thing. And what they are is essentially a abbreviated MRI protocol. So basically, if you took your center's standard non-contrast brain MRI protocol and reduce it by a few sequences just for time efficiency, the real underlying question is the DWI positive or not? And in that region that the DWI is positive, if it is, are there associated flare signal changes that correspond to that region on the flare. And essentially what we're trying to evaluate for is this stroke, and you may hear this terminology also, hyperacute, meaning within the 4.5 to 6 hour time window, because we know, like I said, the DWI is going to be your first MRI sequence that's positive, and then the flare is going to take time before it starts to show signal changes in that same region. And there's around an 80-ish% positive predictive value if there is a mismatch, meaning you have DWI signal but no flare signal yet, that infarct occurred within a 4.5 to 6 hour time window. You know, it is interesting if you look at that data, and I believe we recently discussed this as well in a conference, is if you looked at the patients that they looked at MRI flare mismatch at 6 hours, 9 hours, and even beyond, up to like 40% of those patients actually still had mismatches after 6 hours, which is really interesting. And I think going back to some comments that Dr. Cole and Dr. Scoville made, I think it's going to be really interesting to see what happens with some of these new perfusion indices that we have, like the hypoperfusion index, the CT volumetric index, that really give us an idea of collateral flow, because I believe that may explain some of these MRI findings that basically appear when patients, even though are beyond that 6 hour time window, still have a mismatch, which is interesting. But to summarize, you know, the goal of that study is to determine, one, is it hyperacute? And to do that, look for the DWI and flare mismatch.
Thanks. And so while we're on the topic of maybe determining last known well, which is what we often don't have with our wake-up strokes, or at least an accurate stroke onset time, let me reach back out to Dr. Hall and ask you what practical challenges we continue to experience in deciding on that accurate last known well time, and also the issue of determining pre-stroke functional status, if you would.
Yeah, this is of things that are bring me stress during the treatment and evaluation of stroke. This tops the list, and the ED where these patients arrive is oftentimes chaotic. We're dealing with somewhat limited information, and we need to evaluate these patients rapidly. So we don't have time to sit down and have extended discussions about true onset time versus last known well and baseline functional status. So another important caveat to this is, a lot of times the information that we get is actually second, third, or maybe even fourth hand, depending on how the patient got there. So EMS, very rarely do families show up with a patient initially in the ED. It's almost always EMS. And if that patient comes by air, it's a family to ground EMS and then ground EMS to air handoff. So we're getting third or fourth degree information. And do you trust that information? And, it is not always well understood that time that the patient was found with symptoms, that does not always equate with onset time. And so it's very, it's imperative on us to be very clear with our families that bring a patient in, or with medics, that this designation does have some significance when it comes to treatment algorithms. Was this an onset time? Was this witnessed, or was this just the time that they were discovered? And being very explicit in that. And if you detect any hesitancy in that, then taking a step further and say, here's why I need to know, then sometimes you'll get the answer of, well, I don't really know. And making sure that we're telling our families and our EMS partners that these time-based or time information has effect on the outcome, or on outcome and treatment options. Sometimes that clarifies what they actually saw or witnessed. So be very explicit. One of the most beneficial things that we have done, and you can't do this in real time, but if we can work with our EMS partners, and sometimes this is dozens of EMS partners, to work on getting contact information from family to bring with them. And so a simple phone number and a name of the spouse, a next of kin, a significant other, that can clarify things substantially, especially when it comes to baseline functional status. And so, we use the modified Rankin scale, but in reality, the modified Rankin scale was not really an ED tool to use to figure this out, and to really do a thorough job takes some time to sort out what a patient's true MRS is. that's time that we just don't have. And in many cases, the EMS unit that's bringing that patient in doesn't know what their true baseline functional status is. So that's where that contact information is vitally important. So both of those things are very, I guess, stress inducing, and not just those, but other contraindications to lytics, absolute contraindications. So surgical history, presence of recent trauma or GI bleeds or other absolute contraindications. Teasing all that out is difficult, but having that really close relationship with EMS and trying to get that information from family is probably the best strategy to pursue going forward.
Okay, great. And before we completely leave the topic of wake-up strokes and the use of MRI, let me ask Dr. Cole to help us understand prioritizing treatment decisions for patients who might have been selected for treatment under various different research protocols. So, for instance, when should we be using the MRI wake-up strategy versus simply a late window CT-based thrombolytic strategy? And if the new guidelines discourage the treatment of medium vessel occlusions, how can we know with confidence who should go directly to angiography versus thrombectomy versus who might benefit from that late window or wake up thrombolysis?
Yeah, so I think, now with the ability to treat wake up stroke patients on the basis of, using CT perfusion, I think we'll be doing less wake up MRIs, at least at a center that has wake up MRI capability and CT perfusion capability. Remember though that CT perfusion is not great at picking up on deep ischemic strokes, so those are mostly going to be your lacunar strokes, sometimes brainstem or even cerebellar strokes. So if a patient with one of these, few stroke types is a wake up stroke, their CT perfusion will very likely be normal. And so you wouldn't be able to consider extended window thrombolysis in that patient, at least on the basis of their perfusion study. But you could pivot and should pivot, I think, to doing the wake up MRI to look for the DWI flare mismatch. So that like Dr. Jones said, indicates a hyperacute stroke. And in the wake up trial, they use DWI flare mismatch to select patients for thrombolysis, either with unknown onset or wake up. And so I think those are the situations where you would pivot to using the wake up MRI.
Okay, great. And as our time is winding down, I have a couple of final quick questions. So first for Dr. Scoville, when you evaluate patients who've been transferred from other facilities, possibly with some time delay and potentially with some restricted access to their actual films that were obtained at the referring facility, what considerations go through your mind about obtaining repeat CT, CTA, and CTP images? When should we forego that time delay and take patients perhaps straight to the interventional suite?
Yeah, this is a great question, and it's very consequential. I think the first thing I ask is, has anything meaningfully changed since those first images were obtained? And that includes both time and clinical status. So if the imaging is recent, it's high quality and shows a clear large vessel occlusion, the clinical exam matches, I'm very comfortable going straight to the angio suite. In that setting, I think repeating the imaging costs time without adding much new information. What I do pause is and consider repeat imaging is in these few key scenarios. There's been a significant time delay, especially if we're now several hours out from the original scan, which happens to us, many times. Whether there's been a clinical change, either an improvement or a deterioration in their NIH stroke scale. So typically, if somebody's coming in, just in general, unless it's going to be very fast transfer, like under an hour, I will say, let's repeat an NIH stroke scale, let's see where we are. And then if there's been a change, we can come up to, if there hasn't been a change, we can come to angio. If there has been a change, we'll repeat imaging. And then I think if there's uncertainty in the original imaging, if it's poor quality, incompleted studies, no perfusion data, things like that, where the case is borderline, then we'll repeat imaging. Or if we're making a decision in a large core extended window patient, and we want to confirm that in salvageable tissues like low aspects patients, older aged patients, things like that, where it's on the limits of where the guidelines really talk about, and they're coming from a different facility, we might repeat imaging. In those cases, a quick CT, CTA, CT perfusion can be meaningful in change management. But I think the guiding principle is don't let perfect be the enemy of good, right? If the story is clear, severe deficit confirmed in LVO, imaging supports a target, then time is brain, and I would rather accept a small degree of uncertainty than delay reperfusion. On the other hand, as we expand to more complex patients, larger cores, longer time windows, threshold to reimages thoughtfully goes up because the risk-benefit balance is tighter. So it really comes down to clarity and urgency, go straight to thrombectomy, uncertainty or evolving physiology, take the time to reimage.
Great. And then a related question for Dr. Jones, how worried should we be about the issues of radiation exposure and contrast nephropathy in patients who might undergo multiple studies?
Sure. Yeah. Both of those are great questions and honestly could be hour-long lectures in and of themselves. But I'll address the one that I believe is a little more straightforward first, and that's the idea of contrast nephropathy. And really the teaching and the ideas behind this have really changed over the past decade, as we really started to scrutinize that data that some of those conclusions were made from. We realized it's not really an apples to apples comparison in that a lot of that data was based on cardiac cath patients where the contrast is being injected at a higher concentration arterially as compared to our diagnostic studies, which are usually venous and at lower concentration. So it is the official statement of the American College of Radiology, the ACR, that true contrast-induced injury, CII, contrast-induced injury, is a real entity, but I'll put in quotations, a rare entity. And so you may ask yourself, well, what does that mean for me clinically? What does that mean for the patient? And essentially, that means, if your patient has a contrasted exam, then develops an acute kidney injury, contrast-induced injury should be further down on your differential as a potential etiology. You should be thinking about is other causes for that injury. Is the patient septic? Are they hypotensive? Did they receive another nephrotoxic agent, a nephrotoxic medication since they've been admitted? All those things should be really above contrast-induced injury in that situation. For the question becomes, though, for patients that already have impaired renal function, their GFR is less than 30. That's usually one of the standard marks that we use in radiology. If they have an acute kidney injury already, and I want to be clear, it is not an absolute contraindication to give contrast to those patients, and there's actually not been large data sets that show worsening renal function in those situations when patients receive contrast, but there should be a risk benefit discussion amongst the treatment team, between radiology, between neurology, whoever may be involved in the care of that patient. To one, see one, is it truly needed? Two, are there any alternative modalities that could be considered in that situation? And also, I would say that there are preventative measures that we actually, the ACR recommends, for example, in those patients with either reduced renal function or at high risk, using volumetric, IV volumetric replenishment with 0.9% normal saline, both before and after the imaging study, is highly recommended. And then moving on to the radiation question, I'll use two quick real world questions that patients have actually asked technologists and then were forwarded to me to answer. One being, if I receive this CT scan, what's the odds that it will give me cancer, right? And the true short answer to that is we're not sure. But there's a lot of data out there and a lot of reports, especially in the social media world these days. There was a study in radiology in 2025 that suggested CT can increase your chance of lifetime cancer risk of about 0.1%. But basically, when you talk about radiation and cancer, that's a stochastic effect. That's the term that we use in radiology. And the most widely accepted model for stochastic effects is a linear non-threshold model. And what that means is for every exposure a patient may receive, both in the medical world as well as in the natural environment from various sources, that for every exposure they have, their chance of developing malignancy does increase by some number. But the non-threshold portion means there's no dose that is considered non-harmful, essentially. And there's a lot of debate there and other ideas, and people do PhD work on these things all the time, but that is the most widely accepted model to consider. But I think we can reassure our patients in the fact that we do know, and there is strong evidence to suggest that even if their risk does increase by a certain percent, um, those effects in adult patients or those solid tumors tend to develop decades after the exposure. So the acute problem that the patient's facing now is likely more of concern to them than a potential cancer 40 or 50 years down the road. I will throw in the one caveat, as Dr. Scoville mentioned earlier, since we did briefly mention pediatrics. There is one caveat there that actually pediatric patients exposed to ionizing radiation can develop malignancy sooner. Actually, leukemias can develop in those patients if they're exposed to a high enough level within 10 years of exposure, which is kind of interesting to know. But yeah, both of those are great questions, and I think really go back to the whole, do no harm premise in medicine.
Okay, great. Well, it looks like we're about out of time, so I think we're probably going to wrap it up there. And I will say, as we head out, that there's still a lot of unanswered questions, even though this guideline is extremely helpful in moving forward the care of our stroke patients. I'm sure that if we were to poll the panel here, there would be a number of things we'd love to see show up in the next iteration of the guidelines, and perhaps we can think about what those might be. But let's wrap up there for today. We won't have time, I don't think, for any online questions today, but maybe in part 2 of this, we can bring in some of those questions that have showed up in the chat or other places and address those next time. So I want to thank all our panelists and the organizers. And Theron, any final comments from you?
Oh, I appreciate everything you guys have done today. This is a fantastic. We've got some great comments in the question and answer boxes. So thank you guys for a great presentation. As Dr. Witt mentioned, the questions that we have in the chat that we're not able to get to, we'll try to address those in the next iteration of decision algorithms for the treatment of in acute ischemic stroke part 2, coming your way in June. So I'd like to thank everybody again. Thank you, Dr. Witt, for leading this awesome discussion today. Remember, again, to look out for part 2 coming in June. After today's webinar, you'll receive a follow-up email with a link to review the recording of today's presentation. And it takes about an hour to get to your inbox and your email, along with a survey on the presentation. So please help us plan and improve our future education events by completing the survey. And on behalf of the American Heart Association and our presenters and our panelists, thank you for joining us today. And this concludes today's presentation. Thank you.